So good morning, everyone. Today I am going to start with the last part of the pharmacokinetics, that is excretion. So till now we have discussed about the absorption, distribution, metabolism of the drug, and the last phase of drug it gets out from the body, that is excretion. So at the end of today's lecture, you will get to know what excretion of a drug is, what are the different sites of excretion, then what is clearance, what is half-life, these three: clearance, half-life, and the difference between first order and zero order kinetics. These are very important type of questions from the general pharmacology, which you can get in MCQs or in your theory papers also. So these concepts are very important. So kindly pay attention. So excretion of a drug is irreversible removal of drug from the body, and if we see the this plasma concentration time graph, so when the drug is taken, then after that slowly the with the absorption, the plasma concentration of the drug reaches a peak, and then the from the drug the elimination of the drug starts, and the elimination is when elimination is more than the absorption, then the drug level in the plasma starts to decrease, and then this elimination decreases the plasma concentration of the drug. So, what is the difference between the excretion and elimination? Excretion is a part of elimination. Elimination starts right from after drug absorption, the drug get distributed in the body. So, from there, after distribution, what happens? The plasma level of the drug starts to fall. And there, the elimination. So, elimination includes all the processes which are involved, uh, the metabolism as well as the excretion. The metabolism also makes the drug polar to be excreted out. So the elimination process includes both the metabolism and the excretion, while excretion is simply removal from the body, while elimination will include all the processes which are involved to eliminate the drug from the body. So, what are the different sites of drug excretion? One and the very important one is the kidney. So, in the kidney, so the drug can be excreted through the kidney by the glomerular filtration. Then some part of the drug gets reabsorbed through the tubular reabsorption, and many drugs they are secreted through the tubular secretion, which is an active process. Then the second is from the liver through the feces. There is enterohepatic cycle, which I explained you yesterday also. So from the liver, the drug in the conjugated form is excreted through the bile into the intestine, and from there the drug can be excreted in the feces or from the in the stool, or the drug can be acted upon by the bacterial deconjugation, and then this free drug is taken up back by the portal circulation into the and through the enterohepatic recycling back to the liver, and from the liver to the body. So the drug comes back into the body. Then the other side of drug excretion are the lung for ethanol, general anesthetic. The enterohepatic cycling, yesterday also I told that oral contraceptive pills, rifampicin, tetracycline, erythromycin. So these from the liver, these drugs are excreted. From the lungs, ethanol, general anesthetic, they are excreted. In the sweat or from the skin, lithium or heavy metals are excreted. Then in the tear, it is rifampicin, which is secreted. Then there are a number of drugs which are excreted in the breast milk also. So likewise, these drugs are excreted from these sites. So this I have explained you yesterday that when the drug comes into the liver, it is the glucuronosyl transferase which transfers the this moiety, and it combines with the free drug, and this then again by an active process is excreted in the bile, and the drug conjugate comes into the gut where it is acted by the bacterial deconjugases enzyme, and free drug is formed. Some of the free drug is excreted in the feces, rest is reabsorbed through the portal vein comes back to the liver, and from the liver it can go into the systemic circulation. Drug from the systemic circulation and some also gets excreted out by the glomerular filtration or the tubular secretion, where so the drug comes out through the urine also. So these are the different sites how the drug is going to be excreted from the body. Coming to the kidney, it is the glomerular filtration, and kidney is responsible for the excretion of all water soluble substances, and it is one of the major site for drug secretion. All the non-protein bound drugs, whether lipid soluble or the insoluble, they come to the glomerulus and are filtered out. All the non-protein bound. So it is always the free drug which uh, comes out in the glomerular filtration. Those drugs which are bound with protein bound drugs in the plasma, they are not filtered, since the size of the protein molecule is large, and they are not filtered out. So the glomerular filtration of drug depends on their plasma protein binding. That means if their plasma protein binding is high, the glomerular filtration will be low for that drug. And then the renal blood flow. If the renal blood flow is high, more will be the glomerular filtration. So it is the protein bound drugs are not filtered. And then glomerular filtration also depends then on the renal failure. If a patient is having renal failure, then what happens? Then these protein molecules are easily filtered out, so the drugs can be excreted very quickly, even though they are bound to the protein. And in aged persons also, this glomerular filtration, it can be decreased in such patients. So or in the renal failure also, the glomerular filtration can be reduced. All these conditions lead to a variation in the glomerular filtration of the drug. Then the second is the tubular reabsorption phase, where there is back diffusion of almost 99% of the lipid soluble drugs. And this reabsorption depends on the pH of the urine and the ionization. As I have told you earlier, when I was talking about the effect of the pH, there I have told that the acidic drugs, weak acidic drugs, are less ionized in the acidic media, and vice versa for the bases. But the acidic drugs, they are more ionized in the basic media. If the pH of the urine is alkaline, so the more of the acidic drug will be ionized, and lesser will be their reabsorption. So based on the same concept, I am going to explain over here also. The lipid insoluble ionized drugs, they are excreted as it is, such as aminoglycosides. So a change in the urinary pH can change excretion pattern of the drug. Weak acid ionized more and less reabsorbed in the alkaline urine. So this principle is used in case of the acidic drugs such as salicylate or the barbiturate poisoning. The alkalinization of the urine will make these substances more ionized, and lesser will be the reabsorption and more will be the excretion of these drugs from the body. So in these poisoning, we do the alkalinization of urine, and vice versa. In case of weak bases, they are ionized more and less reabsorbed in the acidic urine. So in case of morphine or the atropine poisoning, we acidify the urine so that these drugs are more ionized and less reabsorbed. Coming to the third stage, the active one, that is the tubular secretion. This is an energy dependent active transport, and it reduces free concentration of the drug. Okay. Furthermore, so when once tubular secretion, the capillaries are there. When the free drug concentration will be decreased, it is the free drug which will be first secreted through the tubular secretion. So what will happen in the blood vessels, which are there adjacent to this loop of Henle? So the free drug concentration will fall in the blood vessel. So what will happen, that more of the drug which are bound to the plasma protein, they will dissociate. So the further more due to this dissociation, again more secretion of the free drug will occur. So this protein binding will facilitate the excretion of some drug. That means more will be the protein bind, more the drug will come for tubular secretion. because the free drug will be formed. Once the concentration will fall, more the bound drug will be converted into free drug, because there is an equilibrium between the free and the bound drugs due to that. So the major transporters for these tubular secretion are the organic acid transporter, organic base transporter, cation transporter, and the pre-glycoprotein. And one very important factor to remember over here is, one very important concept is that this transportation is bidirectional transportation between the blood and the tubular fluid. So what happens, this bidirectional is because all the exogenously administered substance, whether it is a drug or any other xenobiotic, what these transporters do, they will move these substances from the blood to the tubular fluid. Exogenous substances are moved from the blood to the tubular fluid to get it excreted. While for the endogenous substance, these transporters act in the opposite direction. That means the endogenous substances, suppose it is uric acid, so these transporters will help in the movement of these uric acid from the tubular fluid to the blood. That means backwards movement. So that this is a very important concept, and based on this concept, many drugs have been made. They are having the therapeutic effect or the clinical effect is seen. One very important classical example of this is used clinically for penicillin and probenecid. Probenecid is an uricosuric drug. It increases the uric acid secretion in the and so used in gout. And what these drugs do, these are these transporter inhibitors. Okay, organic transporter inhibitor. So what will happen, they, since they are inhibiting these transporters, and when they are given with penicillin, what will happen, that the tubular secretion of penicillin decreases, so the penicillin concentration in the plasma lasts for a longer duration. And that is why probenecid was initially being given, was prepared to for reducing the penicillin tubular secretion and thereby enhancing its duration of action. And similar concept, later on, it was also found that probenecid, what it does by inhibiting these transporters help in the reabsorption. That means in backwards flow from the tubular fluid to the blood of uric acid. So by inhibiting this transporter, what the probenecid is further doing, that it is not allowing the uric acid to be reabsorbed. So the uric acid, which is an endogenous substance which was thought to move in the opposite direction, and based on this concept, the uric acid is secreted out through the in the urine or the tubular. It comes in back into the, it remains in the uric tubular fluid, and it comes out as the in the urine. So probenecid became the uricosuric drug. And these transporters, the salicylate, they also they caused facilitated these transporters, so they resulted in increased uric acid absorption, leading to hyperuricemia. And similarly, quinidine decreased the renal and the biliary clearance of digoxin by inhibiting the efflux carrier P-glycoprotein. So this composition was used to, so as to make the digoxin for its effect for a longer duration. So the renal excretion, the acidic urine, the alkaline drugs are eliminated and acidic drugs are reabsorbed. And this is very important concept. And alkaline urine, acidic drugs are eliminated while the alkaline drugs are reabsorbed. So coming to the kinetics of elimination, so the pharmacokinetic parameters, like this F stands for bioavailability that I have talked earlier, the volume of distribution I have talked. So now coming to the clearance. So clearance is the volume of the plasma from which the drug is completely removed in unit time, and it can be calculated as a ratio of rate of elimination divided by the plasma concentration of the drug. So if we see that if a drug is having a plasma concentration of 20 microgram per ml and the rate of elimination is 100 microgram per minute. So simply rate of elimination 100 divided by the plasma concentration, that is 20. So the clearance is 5 ml per minute. So in each minute, 5 ml of the plasma is totally cleared off this drug. This is what clearance means. So why all drugs are not excreted in one cycle? All drugs are not excreted in one cycle. When I was talking about the tubular secretion, I told that if a drug is having bound to acidic drugs, then it is not filtered through the glomerular filtration. So the drug will last for a longer duration in the plasma, and this binding will also facilitate the tubular secretion only, but the glomerular filtration is not there. So these drugs, the free drugs, the bound drugs, they remain inside the blood vessels, and so they are slowly free drugs are released from this bound site. So these drugs last for a longer duration, and it takes multiple cycles to be presented to the kidney to help in the excretion of such drugs. So clearance is the volume of the plasma from which the drug is completely removed in unit time, and it does not represent the amount of drug. Rather, what it is the it is the volume of the plasma which is cleared per unit time. And total clearance can be of the body is clearance by the renal, hepatic, lung. So it is the sum of all these. So if we see this, this is the organ of drug elimination. Suppose it is kidney, and 500 microgram per minute of drug is excreted. That is the rate of elimination, and the plasma concentration of a drug is suppose 10 microgram per ml. So the clearance is rate of elimination divided by the plasma concentration. That is 500 divided by 10. So it comes out to be 50 ml per minute. So 50 ml of the plasma is being cleared out of the drug. 50 ml of plasma is cleared of drug every each minute. So then coming to the very important concept, that is half life. So what is half life? Is the time which is required to eliminate 50% of the drug, or it is the duration in which the plasma concentration of a drug is reduced to 50% or half of it. So, so it is the time in which the concentration of a drug in the plasma is reduced to its 50%. And it depends directly on the volume of distribution. More is the volume of distribution, more will be the T half, and inversely proportional to the clearance. When the clearance increases, the T half or the time of elimination of 50% drug will be decreased. And if clearance is low, then the T half will rise. So it comes out to be 0.693 into apparent volume of distribution divided by clearance. And it has nothing to do with that starting dose. Whatsoever dose we have given, the whatsoever the starting dose we have given, so it will take roughly around 5 half life for 97% of the drug to be cleared out or to be eliminated. So if this is the plasma time concentration and a drug is being given by intravenous route, we see a very sharp fall, that is alpha. This is because once we are giving a IV drug in the vein, it gets distributed in the body. So rapidly the plasma concentration will fall because it is being distributed throughout the body. Then after that, there is a very straight line, that is the beta curve. This is because of the elimination. The drug is constantly being, with the time, is being removed from the plasma, so it will become a straight line. So this alpha is because of distribution, and this beta part is because of the elimination. So if we are giving a drug X which is having a half life of 1 hour, suppose, so what will happen after 1 hour? We have what will happen to the drug after 1 hour? So the fraction of the drug which will remain in the plasma will be half of the original amount. So if suppose the original concentration was 8 milligram per ml, so after 1 hour, what will happen? The plasma concentration will become 4 milligram per ml. That means 50% will be eliminated. So the concentration will fall by half. We have given suppose 40 grams, so it will reduce to 20 grams, or 40 milligrams, so it will reduce to 20 milligrams. So in the percentage, if we see 100% drug is there at the 0 hour, and after 1 hour, what will happen? 50% is remaining. So with each and every half hour, we see 1/4. So it is 25% remaining. After third hour, it is 12.5%. After fourth hour, half of this, that is 6.25. And after 5 hours, that means 5 half-life, 3.125. So after 5 half-lives, we see that it is the percentage of the drug which is remaining is only roughly around 3%. That means 97% of the drug is eliminated. So coming to the another concept, that is the first order kinetics or the zero order kinetics. If we plot a graph of rate of elimination and the concentration, so initially when the rate of elimination is increasing, so what will happen, and the as the concentration of the drug increases in the plasma, there are enzymes which metabolize the drug, okay, and helps in the excretion. So what will help, the rate of elimination also goes on increasing to a certain limit, then after which the when the plasma concentration is very high, so till this part, this is the first order kinetics, till where the rate of elimination is directly proportional to the concentration. That means a increase in the concentration also increases the rate of elimination, and enzymes are not fully occupied. But once these all enzymes are saturated, that means no free enzymes are there. So if we go on increasing the concentration, the rate of elimination has reached its peak, that is the Vmax, that is the maximum rate of elimination. So the drug is not further, the rate of elimination it does not increases further with the increase in the concentration, and this is known as zero order kinetics. So what is the difference? What from this we can derive that most of the drugs they follow the first order kinetics, while a few drugs they follow zero order kinetics, and that too at very high doses. That means the plasma concentration is very high. What we see, with the increasing concentration, the rate of elimination increases because we have the free enzymes for metabolizing these drugs. But once the enzymes are saturated, the increase of the concentration do not increases the rate of elimination. And rate of elimination in first order kinetics depends upon the concentration of the drug, while rate of elimination in zero order kinetics is constant. So first order kinetics, that means a constant fraction, say 25% or 50%. So a constant fraction of the drug is being removed per unit time. So if we plot in the graph, we will get curved line. While in the zero order kinetics, a constant amount of the drug is being removed per unit time. So we will get a straight line. That means after each half life, suppose here we see 50% is reducing after each half life. So after 1 hour, we see from the 8 it has come to 4, and 4 to 2, then 2 to 1 after 3 half in first order kinetics. While if we see in the zero order kinetics, what happens if suppose 2 milligram per 50%, 2 milligram per ml is reducing with each half life. So after 1 hour, it will become 6. After 2 hours, it will become 4. Then 2 further will reduce at 3 hours, and it will come to 0 at 4 hours. So this is what is zero order kinetics. That means a constant amount is being removed, while in first order kinetics, a constant fraction, that means 50% of the drug is being removed. So T half in first order kinetics is constant. That means a constant amount, a fraction is being removed, so that T half is constant. That with each T half, a constant fraction is being removed. But here in zero order kinetics, T half is not constant, but T half, what happens with the T half? The T half is decreasing because the clearance is inversely proportional to T half, and the clearance here is saturated. So the clearance is not going to, clearance is decreasing, so T half will increase. So the important example, most of the drug follow the first order kinetics, zero order kinetics is followed by ethyl alcohol, phenytoin, warfarin, tolbutamide. The clinical implication of this first order kinetics is that the chances of toxicity is less, because even when we are giving the higher dose, the rate of elimination will increase, because a constant fraction will be removed. So more will be the drug elimination. So the chances of toxicity will be less. But with the zero order kinetics, the chances of toxicity will be higher, because at the when we are having a high plasma concentration, the drug elimination does not increase it. So more will be the drug in the plasma. So more chances of toxicity is there with the zero order kinetics. Coming to the repeating doses at a steady state, that is at the peak, we have the elimination is equal to the input or intake of the drug, and the steady state plasma concentration is equal to the dose rate upon clearance. So what will be the dose rate is that what the target plasma concentration is required into the clearance, and in oral administration we have to divide this by the bioavailability, that is the F. And zero order kinetics, they follow the mechanism maintained kinetics, that is rate of elimination is equal to Vmax into C upon Km plus C. C is the Vmax is the maximum drug elimination rate. Km is the plasma concentration in which the elimination rate is half of the maximum. So if we plot a graph of the plasma concentration at steady state with the dose rate, we get a straight line with the zero order kinetics, first order kinetics. But with the zero order, we see that when the dose rate is high, that means the plasma concentration is going to rise very quickly, very sharply, so that the chances of toxicity is very high with the zero order kinetics. This is because the rate of elimination is saturated. That means the rate of elimination is not going to increase with the increasing concentration. Then again, the very important principle is the plateau principle, where if we are going to repeat a constant dose before the expiry of the fourth half-life, uh, peak concentration is achieved after certain interval. After certain repeated intervals, we will get a peak concentration, and this continues with every dose until the until the increasing rate of excretion elimination balances the amount administered over dose intervals. So we will get a peak concentration which will be reached after certain intervals if the dose is being repeated before the expiry of the 4 half-life, and this is the plateau. Then for the drugs which are not easily quantifiable or have low safety margin, we follow the target level strategy, such as with the anticonvulsant, antidepressant, lithium, or the theophylline, where we maintain a certain concentration within the therapeutic range so as to make the drug very effective. And drugs with shorter half-life are administered at conventional interval of 6 to 12 hours. Fluctuations are therapeutically acceptable. But for drugs which are longer acting drugs, we give the loading dose, and this loading dose is the single dose or the repeated dose in quick succession to attain a target concentration very quickly. This we do with the chloroquine, and this depends on the volume of distribution. While the maintenance dose is the dose to repeated at specific intervals so as to maintain the plasma concentration. Then why do we need the monitoring of the plasma concentration? Plasma concentration monitoring is required when we are using a narrow safety margin drug such as digoxin anticonvulsant. So we monitor the plasma concentration of these drugs so that we do not get the toxicity. And when second very important factor for doing the plasma concentration monitoring is that large inter-individual variation is there with the lithium and the antidepressants. So 2% are not alike. There are large inter-individual variation with these drugs. So we do monitor these plasma concentration. If a patient is of renal failure, so we can monitor the plasma concentration, and based on that we can reduce the dose of the drug. And in case of poisoning also, we do the plasma concentration so as to know how what is the level and how much dose of the antidote or we have to give, or how we are going to reduce it. Then this plasma concentration is not required in certain situations, such as where the response can be easily monitored, such as antihypertensive, diuretics, insulin, where we can easily monitor it, for blood pressure, antihypertensive, we can record the blood pressure and we can come to know. So no need for an invasive procedure. For the drugs which are activated in the body, we cannot do a plasma concentration because we are going to assess levodopa, but it is actually the dopamine which is formed from this prodrug. So that is going to act. So for such drug also we cannot do plasma concentration estimation, and it is not beneficial over there. Then hit and run drugs like reserpine, MAO inhibitors, monoamine oxidase inhibitor. What are these hit and run drugs is that they are going to irreversibly act on their receptors or the site of actions, and even though they are cleared from the plasma, but they are causing irreversible changes at that target site, and because of that their effect comes even though their plasma concentration has fallen down. So even if we are going to monitor for these drugs, we are not going to have some certain constructive results, because they hit the target and they run away. That means their plasma concentration decreases. But if we want to estimate their plasma concentration, that is reduced, but still we are getting the effect. So such drugs we cannot do. It is not useful to do plasma concentration. And there are drugs which are having irreversible action, such as organophosphate compound. So what they will do, they will produce irreversible changes in the target site. So monitoring their plasma concentration also, we are not going to be fruitful one. So thank you. That was all for today.